The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Hi, friends. Welcome back to Sky Women's Health Podcast. I am recording from ISHWISH, the International Society for the Study of Women's Sexual Health fall course, which has been phenomenal. It is so awesome to collaborate with other clinicians and researchers and psychologists. I mean, it's just phenomenal. I will fill you guys in because I have so much more to tell you about ISHWISH and the things that I learned and things that will be applicable to you. But what I want to talk about today is that the FDA removed the black box warning. You probably have all heard about this removal of the black box warning from estrogen therapy. This includes systemic estrogen and local low-dose vaginal estrogen. And I want us to understand why this matters and what we need to note and what the headlines mean, because I want you to feel empowered. Let's start with some stories, though, some behind the scenes. So, 58-year-old who did everything right but was still suffering. So, I have a 58-year-old who comes in to see me, 5 years postmenopausal, has vasomotor symptoms that were well controlled with an SSRI, so an antidepressant. But her genitourinary syndrome of menopause, or the GSM, was devastating to her quality of life. She wasn't having sex, not because she didn't want to, but because it felt like sandpaper. Her urinary urgency was constant. Her confidence had disappeared. Her partner, a retired pharmacist, sat beside her, worried and wanting to help her feel better. But both were terrified of estrogen because of the black box warning, terrified because of the label, terrified because of decades of confusion from the old WHI messaging, terrified because they believed that estrogen caused cancer, strokes, or blood clots. So we sat together for a long, long time. We went through the evidence. We talked about what local low-dose vaginal estrogen actually is, a treatment that delivers microscopic amounts of estrogen to the vaginal tissue with no meaningful systemic absorption. And after real understanding, she agreed to try it. A few weeks later, she came back transformed. No more vaginal dryness, no more pain with penetration, no urinary urgency, no more withdrawal from her partner. This isn't cosmetic. This is relationship healing and life restoring. Okay, I've got another example for you. A 72-year-old who never even opened the tube of vaginal estrogen cream. So she comes in suffering from significant genitourinary syndrome of menopause and vaginal atrophic changes. So that vaginal epithelium or even the introitus, the labia start to thin, become very painful and irritated. We had a beautiful, thoughtful counseling session. She asked the right questions. She left my office ready to begin her vaginal estrogen. But when she got home and she opened that package insert, she saw the black box warning written for systemic estrogen, applying risks that don't need to apply or do not apply to local vaginal estrogen. And she put the medication away. She never touched it. That box cost her years of unnecessary suffering. These two women are not exceptions. They are everywhere. And this is why the FDA decision matters so much. But what does the black box warning removal actually mean? Well, in terms of how I practice, nothing except for perhaps it's going to remove that barrier of fear and confusion. So let's talk about what happened. On November 10th, 2025, the FDA announced it was removing the black box warning from estrogen therapy products. The decision reflects evidence, the medical evidence that we have, acknowledges the misrepresentation of the WHI data, and creates clearer, more accurate labeling. For years, medical societies such as the American Urologic Association, the American College of OBGYNs, and more have advocated for this change, especially for local vaginal estrogen, which has always had vastly different safety profile than systemic estrogen. A huge gratitude to some of my colleagues who were relentless advocates for this to happen, Dr. Rachel Rubin and Dr. Kelly Casperson, who've both been guests on the podcast before. Their work truly helped to kind of move this forward. But why was there surprise? So many of us were expecting the black box removal for local vaginal estrogen, but we did not expect the FDA to extend that decision to systemic estrogen too. So yes, there was a surprise, there was relief, and there was also frustration that it took over 20 years for this black box warning to be removed. And to that, this watching members of an administration that has enacted policies harmful to women's health stand at the podium celebrating this advancement. That was emotionally complicated for many clinicians. And after the recent wave of misinformation, like RFK Jr.'s false claims about Tylenol and pregnancy, hearing him speak at the press conference made a lot of us cringe. Because women don't need more confusion. They need clarity and they need trust. So, this decision at its core is about correcting outdated science and restoring access to evidence based care. But let's do some fact checking because there were some wild claims. So, what is true about estrogen therapy? Let's kind of set the record straight. So, some things that were said. Let's see, claims versus reality. So let's walk through some of them. Let's separate, strong science from hype. So there was a claim that HRT reduces all-cause mortality and fractures. So yes, this is supported by in the right context. So studies show that when hormone therapy is started within 10 years of menopause onset or before the age of 60 in otherwise healthy women, there's an association with lower all-cause mortality. Estrogen helps bone density and reduces fracture risk. So this is well documented in randomized controlled trials. So yes, for many women, starting hormone therapy early in their menopause journey can lower the risk of dying from any cancer and help protect the bones, but timing and individual health matters. Okay, there was a claim that it reduces heart attacks by 50%. This is oversimplified. That's there's more there's some support, but it's complicated. So older observational studies did show very large risk reduction, near 50% in some analysis, but randomized trials like the WHI didn't deliver that universal 50% drop. And later reanalysis strongly support the timing hypothesis we talk about a lot. That benefit is greater when hormone therapy is started earlier within the first 10 years of menopause. And not all women will see the same dramatic effect. And that risk benefit balance shifts depending on age, other underlying health concerns. So, kind of that baseline risk. So, some data suggests that hormone therapy can substantially reduce cardiovascular events, especially when started early, but it's not a magic 50% reduction cut for every woman. And the number comes mostly from older observational studies, and timing is everything. There was also a claim of 64% reduction in cognitive decline. So, a little fact check that is not reliable. It's just a general blanket statement. A small earlier study supported that number, but it's not replicated broadly in large randomized controlled trials, which are gold standard. Larger randomized trials tend to show mixed or neutral cognitive effects depending on their baseline memory and executive function. So observational data do hint to some protection for dementia when hormone therapy is started in midlife, but not a consistent 64% cut. And randomized trials show mixed results. So I don't think that that's a claim that we can hang our hat on. There was also a claim of 35% reduction or lower Alzheimer's risk. Uh, Potentially supported, but very important caveats. Observational and meta-analytic studies show 20 to 35% lower risk of Alzheimer's for some women who start estrogen therapy in midlife, but results depend heavily on when therapy starts, what type of estrogen, and how long it's used. In contrast, studies that started hormone therapy in older women over the age of 65 actually showed neutral or even an increased risk in some causes. So some data supports a reduction of 20 to 35% in Alzheimer's for women who begin estrogen in midlife, but it's not a guarantee. Timing, formulation, individual risk matters. The best thing you can do to reduce cognitive decline and Alzheimer's risk is actually exercise, as reported by Lisa Mosconi's or supported by Lisa Mosconi's research. Why the nuance? Why the FDA change actually matters. So, why are they removing the black box warning now? I think there's been a big push and advocacy to look at the high quality data that we do have that shows that many risks previously emphasized don't actually apply to the same women who are younger, healthier postmenopausal women. Remember, the average age of the women in the WHI was actually 63, so an older population than who were usually starting on hormone therapy. And revising this current, based on this current evidence, removes the barrier, the fear mongering language of dementia, breast cancer, and cardiovascular risk that does not even apply to local estrogen. They are keeping the warning for endometrial cancer and systemic estrogen alone products for women with a uterus because that risk still remains. And so if you have a uterus and you're using systemic estrogen therapy, you have to have a progestogen to protect the endometrial lining. Okay, the most important question women should ask. For decades, women have been asking, what will happen to me if I take hormone therapy? But after this decision and with the data that we have today, I want women to ask, what will happen if I don't take hormone therapy? Will it lead to bone loss and genitourinary symptoms, to severe vasomotor symptoms, to sleep disruption, to mood changes, to sexual pain, to urinary dysfunction? It's not about pushing hormones, but it's about giving women options, accurate options, not fear-based options. And guidelines are not laws, they're tools. And women deserve informed, individualized decision making with a clinician they trust. So overall, the FDA decision is a quality win, a science win, a patient autonomy win, and a long overdue correction. Correct labeling leads to correct education. Correct education leads to informed choice. Informed choice leads to better health. So this opens the door for more nuanced, personalized conversations between women and their clinicians without the shadow of this warning that never belonged on vaginal estrogen and was overly broad for systemic therapy. So if you have been afraid of estrogen therapy, systemic or vaginal, you're not alone. You are responding to messaging that did not match the evidence, but spread like wildfire. And now we get to have a fresh conversation that's grounded in precision, context, and really what's best for you. So if you're struggling with GSM or hot flashes or insomnia or pain with sex or recurrent UTIs or, new onset of osteopenia or bone loss, low bone density, reach out to a provider in your area. You can go to menopause.org or ishwish.org to find a provider who's well informed or find me at Sky Women's Health. We are here to help you navigate your options with clarity and confidence. Until next week, be well.